Hi and very good morning to my respected audience. Thank you to the organizer for having me here. My presentation will be an overview of various options of intraocular lens without capsular support. This would be the outline of my presentation. We shall look into options of IOL with some literatures. Lastly, some cases that we encounter in our center. Before we proceed, allow me to highlight the common causes of losing the capsular support, which can occur in post-trauma cases. Secondly, patients with pre-existing ocular or systemic conditions causing weak or absence of zonules. Thirdly, the most common encounter for most of us is the intraoperative complications of cataract surgery. Lastly is aphakic condition due to other various causes. Now let's look at our options of IOL that we have to replace the PC IOL. The one that we are most familiar with is the anterior chamber IOL, which anchor at the ankle. Iris fixated IOL, which can either be sutured or iris claw. Lastly, which can either be scleral fixated IOL, sutured or non-sutured. Now let's look briefly into AC IOL. I know most of us are very familiar with this lens. Allow me just to highlight a few issues pertaining this lens for the purpose of discussion. As we know, in an experienced surgeon with a good AC clearance of the vitreous and lens matter, patient can still attain good visual outcome with this lens. However, these are potential patients that might have a long-term relationship WS. Either they end up with chronic inflammation or corneal decompensation, as ACIOL causes 16% of endothelial cell loss even in the first few years. Or patient might present with CMO. Lastly, potentially patient can end up having glaucoma due to continuous pigment dispersion from the rubbing of iris. This is one thing we have to remember. Although there are various sizes of ACIOL, the ones that available in hand for us is usually one size. In other words, free size IOL for all types of eye. Hence, post-op sequelae will be exaggerated if the ACIOL is too big or too small for the patient. Therefore, there are relative contraindication for some cases, such as patients with poor cornea, young patients, abnormal angle, or very large eyeball. For iris fixated IOL, we can either suture the IOL or non-sutured. For sutured IOL, traditionally we can either suture the PMMA lens using the 10-0 proling directly on the iris tissue, which is technically challenging. Other option is to enclave the IOL onto the iris, which can either be anterior to the pupil or posterior to the pupil. Visual outcome can be fairly good. In 1/3 of patients, they can have 20/40 vision or better. Artisan lens are rigid PMMA lenses. Wound is usually quite big. Now, we have to remember the anterior iris claw is just another form of ACIOL. In other words, it might still cause endothelial cell loss, although probably to a lesser extent compared to ACIOL. When people start to place the IOL behind the pupil, endothelial cell loss was reduced to only 5.5% at 3 years of follow-up. Let's look at some setback of the iris claw lens. The pupil might become oval. There is also tendency of focal iris atrophy at the enclavement site, leading to disinclination and subluxation of the IOL. Some patient also reported some form of visual disturbances, particularly related to posturing. This is due to relatively poor support of the iris tissue, as it is not a rigid structure. Generally, for sutured scleral fixated IOL, there can either be the 2-point fixation or 4-point fixation. The idea of 4-point is to give a broader fixation base for the IOL and to avoid IOL tilt, which commonly occurs with 2-point fixation. Whereas for sutureless intraocular lenses, we have two options of IOL, which can either be PMMA or the PVDF haptic. For scleral sutured IOL, surgery usually takes slightly longer time to perform. Placement of suture is made outside the eye. Once the suture is in place, then only the IOL will be brought into position inside the eye. Now, let's go to the latest technique of scleral fixated IOL, the sutureless implantation. We will be using the 3-piece foldable IOL. Basically, there are two important issues pertaining to this technique. Firstly, is how to externalize the haptic through the sclerostomy wound. We can either manually pull out the haptic using a forceps or thread the haptic into a 27 or 30 gauge needle, as in Humane technique. Second issue is how to secure the haptic safely. The Humane technique taught us to cauterize the tip with low temperature cautery to create a flange which act as a stopper. Now let's look at some study and sample of cases. This particular study compares between the conventional anterior chamber IOL and the scleral fixated IOL. At 6 weeks post-surgery, they found the sutureless type gives better vision compared to the sutured IOL. Another study comparing between retropupillary iris claw and sutureless scleral fixated intraocular lens. These two lenses located in the posterior chamber. Both do not have scleral dissection. Visual outcome at 1 year is equally good for both lenses. And endothelial cell loss was also equally good at the end of the follow-up. But when they look at the complication rate, the only significant difference was the changes of shape of pupil, which does not occur in the main IOL technique. Let's look at some of the cases that we encounter in our center. This is a case of subluxated artisan lens. A 54-year-old gentleman had cataract surgery with artisan iris claw implantation few years back. He presented to us with reduced vision. There was focal iris atrophy at the previous enclavement site with subluxated IOL. The other end of the haptic is fairly strongly anchoring onto the iris tissue. So, instead of explanting the IOL, we decided to suture back the claw onto the iris tissue using the 10-O-Proline. Suturing was done via a few stab incisions at the limbus. Vision was back to 6/9 and stable up to 5 years post-surgery. This is another case of a 50-year-old lady who had complicated CAT operation few years back. On follow-up, she was noted to have superior corneal decompensation with a tilted ACIOL. Vision was still quite good. When we did the anterior segment OCT, we found that the ACIOL was entrapped between the limbal wound. Explantation was done and we implanted the sutured SFIOL. Vision was back to 6/12 few months after surgery. Now, this third case was a young patient with previous history of iris sutured IOL. She had previous history of trauma few years back. She had lens aspiration and IOL implantation. Vision had been good for her throughout the past 10 years. Until she presented to us with fluctuation of vision for 1 month. When you look carefully, you can see the breaking point at the haptic-optic junction. And the single-piece PMMA lens was actually sutured onto the iris tissue. Again, we did anterior segment OCT, which showed the presence of the PMMA haptic within the iris tissue. She was planned for early surgery within a few days. But just before the surgery, the IOL eventually dropped down into the vitreous cavity. We performed vitrectomy followed by explantation of the IOL. Sutureless scleral fixated IOL was implanted using the Yamane technique. Her vision post-op was back to 6/12. At the end of the day, what is best for the patient depends on what is available in hand and the most comfortable technique for the surgeon. It is not that ACIOL is completely irrelevant, but we do have other better option which worth a try. Personally, I used to do scleral sutured IOL, but lately I have moved to sutureless scleral fixated IOL. We have avoided using ACIOL at least for a couple of years. It is doable. Learning curve is not so bad provided you have the proper instrumentation as well as paying special attention to certain steps of the surgery. Thank you.